All right, here we are. Fire 101.
Oh, well, that I don't care about. Whatever. I mean, we'll just have a sizable SOW. But then it was like,
Yeah, okay, maybe need to mute everybody. Let's see how I do that en masse. Anyway, this is Fire 101. I'm Brendan Keeler from Flexpa. This is a jam-packed presentation, agenda, meeting, webinar, whatever you want to call it. So we're going to go and get started, and people will be joining. And that's great. If you have questions, some of my colleagues, Dylan, Angela, etc., I think will be in the audience. I see Dylan at least. They can field some of your questions. But I'm keeping it interactive. I'll ask you some things about yourselves, what you're looking for, and we'll adapt to the broad array of health and health adjacent people that are here today. So let's jump in. Fire 101. I promised a brief introduction and some of the promo stuff on LinkedIn and the artist formerly known as Twitter. That's not what it's going to be. We got like 60 slides. It's going to be quite a bit of action. I'm Brendan. I'm the head of product here at Flexpa. I'll explain a bit more about me and Flexpa briefly, and then we'll roll through it all. And we'll just mute this person. Great. Who am I? Well, before who I am, let's talk about some goals. And make sure you're on mute if that's possible, everyone else. Some goals for today: to illuminate, enlighten, and teach. This is educational. This is the goal is sort of like the GI Joe principle. Knowing is half the battle. We're all in this together. Health is hard. All those tropes. So we sally forth into the wilderness of fire. Anyway, if you can't tell, I'm pretty casual about all this. So I hope to interest you, perk your interest, entertain you, maybe a little humor, maybe some memes, sort of the Maximus principle. Are you not entertained? So, lastly, don't want to be inaccurate, erroneous, or offensive. Love feedback a lot. So give it to me either in the chat, DM it to me, send it where else. We got the AI, there's lots of AI floating around, and there's one in the chat already. So that's sweet. So yeah, this is the Dewey principle. So who am I really? I'm by first, glance, I was an HL7 analyst. I did this at Epic. So I'm like Mario, like pipe delimited standards. I moved on to CDA, another healthcare standard. So document based. And then more recently, I've become a really big enthusiast in API. APIs are better than IPAs. And so, yeah, I'm sort of an API guy. So yeah, like I mentioned, I worked at Epic, the largest electronic health record system in America. That was great. I did that both domestically and abroad in the Netherlands, the land of tulips. I then moved to Redox, a company for integration, helping business associates connect to the EHRs of their customers that they sell to. Did that in San Francisco. Let's move this guy over here. And then Zeus, an interoperability company helping. This is really annoying. Close you, Slack. Helping people, helping covered entities, connect to the nationwide exchanges. I moved up to Portland. That's where I am now at Flexpa, working in Portland. I also write a healthcare newsletter, Health API Guy, Substack.com. So lots of content there. Check it out. Who's Flexpa? Flexpa is one of many companies that are API driven that deal with interoperability. But really, what are we? We are the easiest way to connect identified claims data in the world before Flexpa, the time before time, land before time with the dinosaurs and stuff. There's no plan data. If you wanted to access claims data, you had to go and you'd be like, United, we're so close, send us something. And they're like, all right, sweet, let's sign this custom agreement. And they send you these broken, weird flat files of claims, breaks every month, it's laggy, it's gross. CMS puts out a rule, patient access API, says you can, there's all the plans have to have these APIs, these Fhir-based APIs. So technically you could go do that, but there are hundreds of plans. Every API is different. Every registration process is different. Payers love to break from any standard or implementation guide that's out there. Really hard to connect them at scale. We connect them at scale. We make it easy. We make it easy for you to onboard and pull identified claims data in Fhir format. So if that's interesting to you, go to our website, ask to talk to us, send me an email, send the carrier pigeon, whatever is your favorite way to communicate. So more important than me or Flexpa is who are you? Because Fhir is a how. Fhir is how you get something done. And all of us are different who's. We are provider organizations. We are apps that sell to providers. We are payers. We are clinical trials. We're VCs who are saying, what's the hot stuff out there? Looking for the cool new companies and trying to understand the space. We're prior authorization, large language model startups. There's a lot of you. And each of you has a different what. You have different problems. And each of those problems demands a different how. And Fhir is one of those hows. But doesn't mean that it's the solution for everything. It is distinctly not. It is good at some things. It is well deployed and implemented for some what's. But there are other solutions and other techniques to achieve your what's. I'm being very general, so let's dive in a bit. There are really three buckets in digital health. You either make software for covered entities, for providers or payers. You make software, you're a business associate. You sell to providers or payers. You sit alongside the EHR or core claim system. There are many of you. There are a lot of different subsystems. You could be a provider organization, either a traditional one or perhaps one that is more digitally native. Those are more popular these days. They're called virtual first care. So your tech and services, you employ providers, you're a covered entity in HIPAA terms, and you either build or buy an EHR. And lastly, there's patient applications, consumer tools. You sell to patients. Maybe you go try and sell to payers or pharma. There's different techniques. And you want to pull data from EHRs, but you don't have a relationship with any of the EHRs typically, or health systems. So mentally categorize yourself. What is your, and maybe you can't because you're a software, make a software development agency or a VC or whatever, but most of you fall into these buckets. They overlap. So like maybe you have multiple products and they fall into different, in the gray areas in between. So here's some examples. Tiger Connect, Phreesia, Stryker, they make software services, they sell it to hospitals, etc. CityBlock, One Medical, Spora, they're provider organizations. Big Health, Peloton, Calm, they're like apps, they're non-HIPAA entities, but they're health rich, they're definitely deal with health. And there's things in between where they have multiple product lines, so it gets blurry. You're like big tech, like where do these things fall? Here's some examples. Care Studio by Google, they make that for providers. Nuance, tools for providers. Apple Health Records, patient facing. Amazon Care, RIP, I think. Right now it's all One Medical, but One Medical as well, provider organization. They have their own providers. Luckily for you, I looked at all of you and I said, what are you? And I put you in your bucket if I could. If you make Fhir tools, I didn't. If you're a VC, I didn't. If you're a provider software, there were so many of you. But this gives you a picture, hopefully a picture really tailored to who you are, of which bucket you fall into. So you see there's a lot of provider software tools and companies. Some of them are EHRs, right? That's a software for providers. Some are ancillary applications. Then there's provider organizations, and some are more new age like MEGA or Oak Street or Strive, and some are OG, like real brick and mortar. UC Davis. I know a couple of you are out there. Michael, I know I see you in the chat. University of Minnesota, Providence, more traditional, but still both provider organizations. And then patient apps. There's not that many of you because typically this is a really difficult, hard space to make any money in, and you pivot into becoming a provider organization or becoming provider software or selling to payers, and then you're not in these buckets. So there's a couple I could see. Apologies if I didn't get around to finding you and putting you into your bucket. What are the problems you are trying to solve with Fhir? Why are you here? What do you care about? These are some guesses. And so put it in the chat right now. If you see one that applies to you, I encourage you, just drop it in the chat. Or if you see one you don't, that doesn't, you say, I actually have another question about Fhir. Put it in the chat, please. Let's hear about it. But if you're making provider software, your biggest one you care about, and like this is almost everyone, is like, can I actually use Fhir to integrate with the EHRs of my customers? It's going to be a ton of you. Guarantee that's why many of the provider software groups are here and are listening. Provider organizations, you have a lot of questions. How should we use Fhir within my enterprise? Can I actually use Fhir when exchanging with external organizations in the healthcare ecosystem? How do I comply with the Fhir mandates? Patient apps, sort of like, can I use Fhir to access the data I want to as a non-HIPAA entity? Anyway, that's the intro. Here we go into the actual agenda, and let's go fast because we're already 12 minutes in. Data standards. So before Fhir, what is even a standard? Because Fhir is a standard. If you go in healthcare, if you operate, you'll see this XKCD thing, all the time. You'll hear people say, if you've dealt with one instance of X12, you've only dealt with one instance of X12, or if you've dealt with one instance of Fhir, you've only dealt with one instance of Fhir. All these are standard tropes and jokes, but this one in particular is true. It just grows. There's growth in standards. We continually redefine new ways to say this is uniformly how we do something. And so there's been a growth of standards, and healthcare as an industry has more standards than almost any industry. It's kind of weird to think about. We think of ourselves as backwards. We're very standard forward. So what exactly is a standard? It's an agreed upon method for connecting systems. If we didn't have them, it'd be like this party over here, everybody talking a different language. Nobody understands what's going on. You can see this guy's face. They may pertain to security. They may pertain to data transport, to data format, to codings. To learn one is analogous to learning a language. If I can learn Spanish, I can learn English, it's much like learning X12 and learning EDI. Different languages, different formats, different grammar. You pick it up, you can read it, you can write it, you can sing it. And ultimately, it's a product. These are products based on the consensus of the people. It's not some autocratic, like this is the way. It's really consensus based, both to the success of them and to the detriment. So what are the different types? Transport, how do I send it from A to B? Security, how do I secure it from A to B? Content, what actually is sent from A to B? And then coding, so definitions, like the words within the sentences of content. Here are the many examples you'll find in healthcare. All these transport standards, gross, real gross stuff. Security, all the ways that you can secure the transport standards to make sure nobody can steal this very sensitive data. The content standards, the way we turn the database, your custom database, into something that someone else can understand. And Fhir is one of these. And then the code systems, the terminology, the ways within the content that we say, this medication is this medication, this procedure is this procedure. We care mostly about content standards today. We're talking about Fhir, but Fhir uses code systems, codes and terminologies. You'll see them by using Fhir. And you transport Fhir and secure it with these other things. It's agnostic to this. I could send Fhir payloads over SFTP. I can send Fhir payloads over email. I have. I'm a sicko. All right, so what's not a standard? Doing something your own way. You know, Apple and Android, they have their own APIs. Those aren't standards. It's not necessarily a bad thing. It's well defined. If it's ubiquitous, it's easy to use, and that's great. However, for EHRs and other places in healthcare, historically, proprietary formats were a barrier to entry. They had shit documentation. They're expensive, and they weren't meant to align incentives. They were meant to prevent you from connecting. Hypothetically, now we are approaching the platform approach, the Salesforce approach. Come and build on us in healthcare. And you see that from, first Athena and then Allscripts as EHRs, building themselves sort of as platforms, saying we have open documentation, we have great support, hypothetically, broad marketing and distribution, hypothetically, and aligned incentives, hypothetically. Who makes them? The big baddie in a good way, really good way. HL7 is awesome. And they make most of the standards we talk about and deal with. They also have DICOM for images, NCPDP for pharmacy standards, meh. X12 for, well, they make a lot of standards, but in this case, claims and eligibility and all the stuff we use for payment. Both of these are not my favorites. They're not open. You pay to play. They don't really iterate fast. HL7, a lot better, or has improved a lot over the years. IHE, they do some standards too. We got ANSI and ISO, ASTM. ASTM would sort of tried to angle to be healthcare standard, and then HL7 kind of rocked them. It's pretty interesting history back then. Anyway, ANSI and the ISO, they make standards about standards. They're like exhibit. Yo, I heard you like standards, so I made standards for your standards. Anyway, joke. Hopefully someone laughed at it in the silence of their mute. What makes a standard successful is if they adopt it. Like I can go up in the ivory tower with my team of consensus builders and come out with the like Moses with my here are the standards. And if people go, I don't care, then it's like Simba right there going through the elephant graveyard. There's just so many standards that nobody used. And you know what that means? They don't matter. Useless. So these are products, they're launched. And if you are off mute, then put yourself back on mute. Anyway, so why do standards get adopted? Well, customer demand, consumer demand. If it meets their needs, if it's well documented, it's easy to use. Just like everything for any product, people will just go and use it. Or if it's government required. If the Fed or the states say, you got to do it this way, probably going to do it. De facto standards can arise, right? Like if everyone starts saying, starts using something, then it turns into a standard, and then eventually it gets turned into a real standard. Anyway, historically, we all shuttled around PDF and Word documents. Now we're living this beautiful age, at least for HL7, of open, online documentation. You can read everything about Fhir. You don't have to pay anything. Sweet. It's not how it was 5 or 10 years ago. There's 3 main formats of content in healthcare. There's EDI, that's the oldest. There's XML, the middle child, the ugly stepchild in the middle, and then JSON. We all love JSON. This is EDI. It's not super fun. You can sort of read it. If you squint, you see some stuff. It's delimited by pipes, hence the Mario joke earlier. That was kind of tough. It was made in the era of like trying to keep compact messages. People said, what if we made sort of human readable? And so they use XML. So there's a number of XML standards that are, you can sort of parse out the formats here of, you might say, okay, the identifier is this identifier. You can read it. You can, but XML, it's like really, it's like a 2000s. It was very in vogue in the 2000s. It's very finicky, I guess is the best way to put it. But that's what we use. Like it's very dominant for certain things in healthcare. CDA documents are XML. E-prescribing. This is e-prescribing. If you're sending any e-prescription, it's going to be XML, NCP2P. So there's stuff out there. And then JSON. JSON is sweet. JSON is, everyone loves JavaScript these days. It plays well with that. It's human readable. Go team. Fhir is XML format. Fhir has other formats. Most today, if you're playing with Fhir, then you're going to be using JSON. Anyway, what are APIs? Because that's not just standards, it's APIs. Well, APIs are just getting really, really popular these days. It's a way of connecting. Everyone loves them. But like, what are they? Well, before Gen Z was born, there existed APIs. There was this sort of object-oriented programming, had this concept in Java and C++ of a remote API. But it wasn't really what we think of an API today. That started to take place. Salesforce and eBay, they said, we're going to have these web services. If you want to connect to us, you can use XML with these web services. And people said, oh, that's kind of neat. I could build on top of Salesforce and eBay, these dominant platforms. But really, the most modern API takes off in 2005-ish. We have Facebook and Twitter, rest in peace, now X. And they had web APIs. I could use JSON and REST to connect and build on top of these platforms. And then there's public APIs or open and self-service and just kind of, user-friendly with, it takes off with Amazon and S3, and then there's APIs everywhere. So then we have the question of when is there healthcare's API? We have standards, but we want an API. There's so many, it's so easy to use. It's web-friendly, used everywhere else. So there was an ill-fated attempt with HData. That failed, but then they launched Fhir. That's healthcare's API. So we're in 101. Let's just talk about it. It's the newest content standard for exchanging healthcare electronically. Fast healthcare interoperability resources. So they said, let's take the best part of the API revolution. Let's have an API in healthcare. Make a standard one so that everyone can just use it. And we don't have to deal with all the bullshit of HL7 or these prior technologies. So let's use the best technologies out there from the web: HTTP, JSON, OAuth. One thing they fixed out of the ill-fated journey known as HL7 version 3, an XML standard, is that it was an academic standard. It's very prescriptive. It was not flexible. You must be this big-brained person up in up in that ivory tower to even understand what the heck you were doing. And so they said, let's make it implementer friendly. Let's make sure there's flexibility. Let's make sure you can extend it. Let's make sure that it meets a variety of use cases. That comes with trade-offs, but it's there's benefits because that's the reality of the world. And so as of the version we're on now, we're on the one that is dominant in the US is HL7 R4, or sorry, HL7 Fhir R4. That comes with 146 resources. So things like the patient resource, the demographics, the medications, the procedures, each of those is a different resource. And these are standard things to communicate about in healthcare. Wow, you say, Brendan, that's 146. I can do so many things with those. Unfortunately, it's not really everything that's in the specification. And so one example, historically with HL7v2, if I was trying to build, things were pushed to me. So it was pushed out from the EHR. I would just listen to this sort of webhook, and then that was how I interacted. Fhir is a different way. It's query based. So you say you say patient, do you have my patient? And they'd respond and say, here's your patient. It's different. So there's some changes there in terms of the delivery mechanism. As you're designing your workflows, you need to account for what's real, because Fhir has a webhook, sort of. The webhook is the left one here. They have that in their spec, but it's not out there in the wild. So we'll talk about that a bit more later. So what is it really? Well, it's not 146 resources. What you can guarantee from the EHRs, if you're looking to connect to EHRs, which a lot of you are, is just what's been required by the government. That's only 18 resources. The US Core Data for Interoperability, USCDI. So when Cures Act came out, and we're going to have a different webinar in the future about, regulation. The Cures Act came out and said EHR's got to go do fire. Here's the fire they got to do. It's only these 18. And it's only 3 access methods. An application being able to pull for one patient, if the patient authorizes. A provider who's logged in being able to pull these for the patients they care about. Or bulk query, sort of saying, here's a population, give me this information. So that's great. Like, that's a cool capability, but it doesn't serve every workflow. So if you're just saying, what can I do across all EHRs, guaranteed, this is it for now. There's no write capabilities built in required by the ONC, the Office of the National Coordinator. And so what that means is you're very limited in terms of guaranteed scalable capabilities across all EHRs. However, some go further, and we'll talk a little bit later about which EHRs go further. They said that we like Fhir, we're going to build more. The Fhir ecosystem is great. And like, this is one of the cool things. It's very participatory. Come and join. There's tons of work groups. They're advancing very specific things. Da Vinci for payer-provider interactions. Historically, it's like, is anything going to happen there? Now, tons of stuff. That's their implementation guides are being used all over the place. Argonaut, provider interaction and implementation guides. This is like the core stuff that's been used. This is the dream team. The people in the Argonaut, like, that's like the Avengers. Back when Marvel was cool, I guess. I don't know when that was, but Karen, that's for patient access. So they have very specific work groups. They advance implementation guides, and the industry chooses to adopt them or not. So for instance, Codex, like, that's cancer care and research. They're not really like, is it being adopted? Maybe a few implementers. Like, the things that are built need to be adopted. That's key to remember. So when you read things in specifications, they're not real yet. You got to find people who are using them or know that people are using them. So some cool things about Fhir, open documentation, like I mentioned, really awesome. Great community. There's a chat you can jump into, chat.fhir.org, and you can just go and ask and say, here's my question. It could be dumb, it could be really smart. And you have the guys who wrote the spec just responding to you like day in and day out, and other people too. It's a great community, great developer community, great everyone community. Patients are in there. Yeah, so that's awesome. Also, Fhir tools. So there's a number of them. You've seen the cloud vendors adopt Fhir. So they all have built-in tools. Some of them are good, or pretty good, like Google. Some of them are less good. I'm not gonna say which one, but it's Amazon. But they're getting better. The point is, there's open source and other tooling. These are all pretty good. They're all at least worth consideration. But we at Flexpa have one that we love the most and we use. So that's MedPlum. MedPlum is an open source Fhir server. They're great. And I'm hoping someone from MedPlum might be on to briefly talk about what they do. I thought they were going to be. I guess not. That's okay. Well, they're a Fhir server. They're open source. Great developer community. What else is there to say? We love them. We use them. They're better than other Fhir servers I've used before. And if you want to build an EHR, they're really good at that too. What's some problems with Fhir? So, like I mentioned or hinted at, the Fhir docs make it be like, holy moly, there's so much I can go and do. That's sweet. I'm big, strong dog. But Fhir in the wild is significantly less strong. It's a crying dog. It's not really crying. Like, there's things you can do. It's a happy dog, but it's a less buff dog. That's one, is that you read something, you're like, I want to use this. You go to talk to someone, they're like, what are you talking about? We haven't implemented that. Implementation is the real challenge, not the specification. And then divergent implementations. So there are common problems to be solved that haven't been defined in an implementation guide by Fhir or Fhir work groups that people solve in different ways. So what do I mean? Here's an example. EHR vendor. I'm going to create a Fhir API for scheduling. Me, a developer. oh, the same resources as other EHRs, right? Not true. Not the case. You look across the major EHRs, they've all done like open scheduling 3 different ways. That's just one example. There's many examples of, yeah, you have to start to think with the different servers you connect to. You're not just doing it once and then scaling, you're dealing with different divergent implementations, all using Fhir, but slightly differently. So the adoption mirage, what does it mean? It means that, I don't know, when you look at this, you're like, oh man, the mountain is huge. There's so many, like the industry groups have defined so much. But then you start to look and you're like, wait a minute, the mountain's not as big as I thought. The vendor adoption, is what matters. And then you look a layer deeper and you're like, wait a minute, they developed something, but it doesn't matter if the health system hasn't deployed those capabilities. And so what the reality is that the reality of Fhir is much smaller. The impact is always much smaller than what's defined in the standard. There's a lagginess between what's defined in the standard and what becomes real. And not everything becomes real. So what comes up? How do you scale this mountain? How does it get pushed up? There's 3 main ways. One is regulatory pressure, one's customer demand, and one's strategy. Regulatory pressure. ONC says, go do this. Generally, people are going to go do this. So meaningful use. They said, go do NCPD and CDA, NCPDP and CCDA, and everyone did it. Now it's uniformly deployed across the industry. TEFCA, now they're saying, okay, CCDA, XDS, this is really the way we're doing things. You're going to see that become even more cemented than it was. And then 21st Century Cures, so the go do Fhir for patient auth, go do Fhir for some business associate exchange. And so we'll see Fhir uniformly deployed, but only for those 18 resources I mentioned. So after that, what comes next? Like ONC is not saying something, then how's it get done? Customers, they ask. So Kaiser goes, please do the Fhir. And Epic's like, all right. Emory's like, please, Cerner, do some Fhir. And they're like, not right now. We've been bought by Oracle. We got some other things to take care of. And then you have South Coast Pediatrics and like, Cario, do some Fhir. And they're like, we already did the regulatory stuff. No way. I'm dunking on them. But like, it's true that you look at like these deployment of these long tail EHRs. They're not going to do if it's things that aren't regulatory required because they have to take care of the core features of their own EHR, and building APIs, external APIs, isn't what their customers are demanding all the times. Lastly, you can have forward-thinking strategy. So Canvas, for instance, or an EHR, a new age EHR, and they said, what if we made our API all Fhir? So they were thinking, okay, let's be strategic. Let's lean into this. People might buy us for that reason. Okay, but you can't bank on every EHR having that strategy, unfortunately. So yeah, let's continue on. So early on, we talked about who are you, what like, are you a provider software, are you a provider group, or are you a patient app? Well, that defines your trust paradigm. So like, how are you trying to connect and use Fhir can be kind of mapped based on your role. So interoperability. Within an enterprise, an organization, a covered entity needs to connect to a business associate. Interoperability between different enterprises. So covered entity to covered entity, hospital to hospital, hospital to pharmacy, hospital to payer. And then patient authorized exchange. Non-HIPAA entities using the patient and the right of patient access to gain access to information. So covered entity to the patient and the patient to whoever they want to share it with, their choice. So interoperability is connecting the systems within an enterprise. It's the oldest, it's like we've been doing this since the 70s. EHRs in the system. There's a lab system. How do we get stuff back and forth? So there's contracts and business associate agreements. And the ways what you're going to do and what you're going to see is that there's a lot of variety. There's HL7v2, there's SFTP, there's proprietary APIs, and there's some Fhir now. But it's not everything. Fhir didn't rip and replace all this history, all this legacy, all this baggage. So if you're an application selling to a hospital or to a payer, you're going to have to deal with a wide variety of connectivity methods. You cannot just assume that Fhir is going to solve your problem. It may be the how, but you need to be open to many other hows. May be hard to swallow. The HRs are not ripping and replacing HL7B2. They're leaving those capabilities and they're saying, okay, now we made the Fhir stuff for compliance, or we made some new capabilities. Interoperability, broadly overused term. I'm using it here very specifically for networks of exchange. I'm talking care quality. I'm talking direct trust. I'm talking Commonwealth, SureScripts. All of these are the visas of healthcare. They facilitate exchange between organizations. And so those transitions of care between enterprises, that's interoperability to me. And there's usually one agreement per or contract for each of these networks. Most of these don't use Fhir. Almost all of them don't. They use old standards. They use X12. They use NCPDP. They use CDA. And so you have these on-ramp API companies that say, you want to use Fhir, great. You can use Fhir, but underneath the hood, it's not Fhir. It's a CCDA document. So just know that there's a translation happening. You're not natively sending, Fhir over to the Epic instance over direct trust. It's being turned into a CCDA and it's being pushed in. You're not pulling, via Particle or Healthcare or Zeus in Fhir. It's a CCDA and it's being decomposed into Fhir. That's okay. Just something to be aware of. Lastly, patient authorized exchange. This didn't exist. Like patients had to go and be like, knock, knock, hello, UC Davis, can I have my records? The HIM department would be like, here it is, here's past $10. And then you get the PDF or like maybe the printout. Now, with my patient portal credentials, I can type it in, I can authorize and authenticate and authorize and share data to the app of my choosing, all in Fhir. Just that USCDI data, but still, that's a sweet capability. So very much similar to Plaid and FinTech. You can authorize with your bank and pull in your information. Thus, too, with providers and payers now. So what's the map of it look like? Okay, there's some Fhir. Like you can expect some Fhir with EHRs if you're building a business associate application. If you're Agathos and you're selling, maybe you're using Fhir. If you're any of those ones earlier that I mentioned, if you're Well Health, if you're a covered entity, if you're Oak Street or you're Strive or whoever, some of those other ones in the audience, okay, maybe you can use Fhir if you're using the on-ramps, but you're not really using Fhir. Maybe you can use Fhir in your enterprise, but like for the enterprise, for the capabilities between organizations, we're not there yet. And then if you're a patient application, Fhir is that's all that's available unless you're doing manual record release too. So this is a summary of what I just said. Should have jumped to this slide, but before it was just HL7, vendor APIs, flat files. Now you get some Fhir for interoperability. Interoperability. It was CCDA, it was X12, it was NCDP. Now it's still that, but there's Fhir on ramps. And then patient authorization, nothing, now Fhir. That Greek mythology. We have Fhir. I bring you Fhir. Thank you, ONC. Anyway, Fhir strategy. You now understand a little bit about Fhir and like maybe you can use it, maybe you can't. Brendan, tell me more. Okay, we got like 20 minutes left. Let's do that. Reminder, provider software, provider organizations, patient apps. You are one of these three, unless you're like VC or something. Like if you take away nothing else, this is like how you can figure out most of your problems in healthcare is by starting with these principles. Hugely important to understand that. Somehow people keep missing. So tools available to you. Well, if I'm in the provider software thing and my reason I'm looking at Fhir, the how is I'm trying to connect to an EHR. That's your not your how, that's your what. I've sold to a health system. I want to connect. I need to do my job with them. I need data from the EHR. It's like most of you that are provider software or payer software, you can use these tools, and not all of them are Fhir, but you need to think about them. They're all hows to accomplish your goals, and that's more important than Fhir. Than being if you're really, really religious about a how, you constrain yourself artificially to accomplish your goal. And you're doing your job in a way that is wasteful of the VC money you've raised. So EHR programs, all worth consideration, both fire and not. Here are some of them. Epics, great little program. Hilo, not so great of a program for eClinicalWorks. Athena, well-developed legacy program. They continue to iterate. Cerner code, pretty decent. Allscripts, very well developed. Plenty more. Interface engines, so tools you can buy that can sit in between to make your life easier, to not have to deal with all this because they have adapters and all those things. Some listed here. Check them out. Managed services, you have Redux, very dominant. My old employer, love them to death. So worth some consideration if you're saying I want the benefits of a tool, but also some people that know what the hell they're doing. Health Jump also plays in that space. Next Health, but plays in that space, but really only for dental EHRs. Lineate, sort of off-brand Redux. LK, One Up Health. Yeah, that's the lay of the land. Some articles about it I'll share at the end. If you are a provider org, you're saying, I have different jobs to be done. I need to retrieve clinical data. Okay, great. Health Gorilla, Zeus, Particle, Redox, No2, all on-ramps, all Fire-based on-ramps even. You have networks for ADT data, like patient ping and collective medical. You have specialized services, like maybe you want to go and prescribe something, TruePill, Axel Health, Wheel. You have the on-ramps to SureScripts. And then you have things for like eligibility. So these are all different jobs to be done. Some are not Fire, some are Fire. But you as a provider organization have a ton of different things. It's not just one problem. For provider software, it's almost one problem. It's like, I need to connect to the EHR. As we started with, as your provider org, you have a ton of different things. And Fire as a solution might play in there, but it depends on what you're trying to solve. So you got to drill down a layer. Lastly, if you're a patient app, you can get clinical data, via the things that are listed here. So One Up, Human API, One Record. Wearable data, there's a ton of these companies. There's more than even list here to pull from, like Apple Watch and all that. And then claims data. It's us, Flexpa. You should come talk to us. There's other options, but we're the best. We're better than the rest. Some of these are Fire-based. Flexpa's Fire-based. Some are not. The wearable data companies, I don't think they're Fire-based, any of them. So, like, should you do an EHR app program? Really something? Oh, sweet. That's great to hear. In the chat, it says Terra has Fire. So, yeah, should you do the app program? Maybe, depends on the app program. It's worked for some people. Maybe it works for us. Here's some like perspective. Okay, Epic. 4 Fire emojis. They have the baseline Fire. They have more. They have write capabilities. Not everything you need, but at least they've gone beyond. They keep extending it. They keep doing more resources. A lot of resources to pull, well beyond the required. Some to write. If you want to do it, you can use legacy standards. They document that at OpenEpic. You can check out the patient side or the provider side capabilities via fire.epic.com. Or if you need more, you're like, I need stuff that's beyond, I want to use APIs, but Fire doesn't do it for me. They have vendor services. So you can check that program out. You'll pay them some money. If you get deployed and they like you, you become a partner or a pal. Cerner, like they've sort of built up the same, like you can be a consumer app, you can be a provider app, or you can do value add services, but it's all Fire. They don't have other APIs. They have other legacy standards, lots of HL7 and stuff, not openly documented. So it's not listed here. Athena, excellent marketplace program, great proprietary APIs. Hope no Athena people are on the call, but like lackluster Fire, like very bare bones regulatory minimum stuff for patient and provider stuff. They do document their legacy, HL7 and other interfaces, so that's pretty sweet. And then Allscripts, eClinicalWorks, they have Fire for patient and provider. So this should just be linked in these two places. As you go down the long tail, increasingly unusable, less developed, Fire APIs and API programs. So general resources, the Fhir docs are amazing. The community, as mentioned, is amazing. This presentation was based on an old article I wrote about Fhir. So if you're more like long form and less listen to a video and my voice, I hope to never hear a recording of this because I hate the sound of my voice like many people. Maybe you do too. Oh, in terms of my voice. You can read it, is where I was driving with that joke. Video. Smile CDR, their Fhir server. They have a great intro to Fhir. Recommend that. Josh Mendel, one of the smartest people in the Fhir community, but honestly in healthcare technology. He's got some intro videos. His colleague Gino, also really smart, but both are Microsoft. Some more intro. My old colleague Nick Hatt. I guess this is a triumvirate of really smart people because Nick's a genius, has some more stuff. And then some practice. You can practice with this exercise. I'll send these links out to everyone afterwards. Some nice exercises to get familiar. And the EHR sandboxes are a great way to get familiar and practice and play. More specifically, for each of you and your use cases, I have articles, both my own and others, but mostly my own, because I write things I want you to read. So if you're provider software, how to integrate friends and win systems, it's not specifically about Fhir, but it's about how to do the job to be done, which is to integrate with the EHR you're trying to integrate with. And you consider all options to do so. And second, and like sort of tag teaming with that is Super Integration Fighter 3. Interfaces, standards are only one way to integrate and connect. There's some other like dark arts, direct to database and RPA. It's another how. Maybe that works for you. Maybe it's the right thing for your situation. You must consider it. If you don't, then you're being dogmatic in a way that you shouldn't. And then Chipple. So this is the ONC's list of certified products. It's a really good resource to find links to every Fhir API. You can go here. You can search for the EHR, every EHR Fhir API. Go here, search for the EHR. Hell, let's just do it. Let's do it live. Not that. So we go here. And either my internet is slow and this is a terrible demo, or I'm gonna blame ONC for this. We go here, we say, I'd like to see Epic's EHR. So I search and it says, okay, here's Epic. Here's all their products that they've certified. And I say, let me see for Epic Ambulatory what their Fhir API is like. So I click and drill down in. It takes an annoyingly long time to load. And I scroll to the right. API access. So that is G10. And under G10, I see links to API documentation. So that's really cool. Like, go forth and prosper. Use this. If you're trying to connect to EHRs or understand EHR Fhir APIs, what a great tool. Go ONC. Anyway, for provider organizations, you are trying to do so many things. And there's actually like two subcategories of you. There's traditional organizations, and then there's those digital health provider organizations. For the digital health providers, and also for the traditional, the Guide to Interoperability by Elion. Elion Health is a great resource about different tools out there in digital health. I collaborated with Bobby over there, and we wrote this Guide to Interoperability. So it's written for you, talks about all the jobs to be done and the tools that are out there to solve them, the networks, the on-ramps. So some are Fhir, some aren't, but it's more about what you want to solve, not how you want to solve it. Cures, you should understand what the Cures Act is and what it means. This article gets into that. The Tale of Ramps and Rails plays well with this one up here. Patient apps, there aren't many of you for good reason. But if you're interested to understand why it's hard to be just a patient app and not turn into a provider org or provider software or payer software, this is the article to read. And it talks about Fhir. Additional resources, ONC's website on standards, some other history of HL7 that's pretty fun, the history of standards I wrote, some information about trust in healthcare, those 3 categories, whether or not you should get an EHR if you're a provider org, whether you should build or buy, and then another article about API companies across healthcare and beyond. This is my contact information. I'm a health API guy on Twitter/X. You can find me on LinkedIn as Brendan Keeler. You can find my Substack at healthapi.com or substack.com. And these are my emails. I want to go back to MedPlum and give them another chance, if they're here now, to talk about what they do, because I promised I would.
Hello. So sorry I missed the previous one. Hi, everyone. I'm Reshma from MedPlum, and really glad to be here briefly. We work with Flexpa and others to help make a Fhir native applications, and we also have like an integration engine that allows you to connect to lots of different other kinds of HL7 v2 interfaces, Fhir, and very, I don't know if you talked about this, Brendan, but also Firecast we have support for. And I won't really belabor this, but we are an open source company, so I'll share my repo. If you are interested, please join us and hang out.
Well, before you got here, I did give a good hype. I did not mention Firecast. We'll save that for the 201 or maybe the 301. But like I mentioned earlier, for everyone in there, Firecast, CDS hooks, Fhir has a lot of stuff that's out there, not fully implemented. We talked about the basics, USCDI. There's tons of cool stuff that really innovative, awesome, forward-thinking companies strategically are thinking about, like MedPlum, that you can take advantage of. So
Firecast, interestingly, has a rollout, but not in EHR. It's in PACS. I digress. But there's more about it on our site and on our blog if you all are interested. And I'm around too. I don't want to take too much of your airtime, though. Thanks for the shout out, Brendan.
For sure. So with that, we are 7 minutes shy. I went really fast. I thought it would be long. I was right, but I was also wrong. What questions do we have? So toss them in the chat if you have any. Sure, that's a good one. So Michael asked about Tefka and QHINs. A little outside the domain, maybe a separate webinar to come, but what are those? If we go back to, where was it? Oh, ahead. Here we go. Networks. So, good Lord. Interoperability. I want to exchange between my org and another org. I use networks. I use Care Quality. I use Commonwealth. I use SureScripts. I use Direct Trust. The newest and greatest is Tefka, coming from the Cures Act. Trusted Exchange Framework and Common Agreement. It is live as of last week. People are switching over from Care Quality. It is largely to start similar to Care Quality. I can pull data from one care institution to another. I can pull from UCSD, I can brought to Kaiser and vice versa for treatment purpose of use. That's what Care Quality does today. And that's what Tefka will do. It was point one. So no, not a huge change there. There's some push capabilities, except now individual access services. So there's a new purpose of use for across these networks that says, I, the patient, can selfie and identity proof and show who I am in a way that is strongly credentialed. I have a strong identity proofing, and then pull across this network. And so that's live. People are starting to do that. All Epic sites are live. The network is not as fully deployed as Care Quality quite yet, which is a framework, right? This is people make that distinction, but it's growing, and there's other QHINs, qualified health information networks, that are, there's only 5 to start, but there's others waiting in the wings, like Commonwealth and No2, that once onboarded will make the network as large and hopefully larger than care quality with a broader set of purposes of use, treatment and individual access services to start, and potentially more in the future. That is not Fhir based. It is CDA based to start. There is a roadmap to get to a Fhir native version. But to start, if you're trying to use Fhir and interact with TEFCA, much like most of these networks, you will use an on-ramp. You will use a QHIN that offers a Fhir API and then translates to the underlying standards. You will use a participant. So a participant is one layer down. So maybe there's a participant that sits on eHealth Exchange and says, okay, I'm a participant. I'm going to make a nice API that's Fhir based and then offer that to certain customers. So those on-ramps can keep you Fhir native, even in a world that still exists that is not. Okay, hopefully, let's see, question number 2. Is USCDI Plus on your radar? Is that USCDI? Maybe, Amy, you want to say your question. UDS Plus. Not sure what UDS Plus. I do know what USCDI Plus is.
Yeah, you can hear me, right?
Yep.
So part of why I signed up for this talk, I had heard you on the Health Gorilla podcast a while back. So that's how you were on my radar. And I signed up for this webinar because I'm the new kind of product manager on this initiative. So I work for a company that supports federally qualified health centers. So UDS stands for the Uniform Data System. It's what HRSA requires as far as clinical and demographic data from all of the health centers that it funds. And so UDS Plus is a modernization effort in which we are supposed to, instead of like in the past, we would help the federally qualified health centers through mappings and reports. We would help them generate their numbers for their numerators and their denominators and their buckets that their patients would fall in. And now basically HRSA is saying, instead of giving us just numbers, we want you to send de-identified patient data and clinical data, and then we will warehouse it and analyze it ourselves. That's essentially the long story short. And so we're just trying to figure out kind of how to make that happen, because Athena Practice is the main EHR that we serve, not Athena One. I'm also very familiar with Athena One's APIs and their Fhir APIs, but not Athena Practices. So I don't know. I just didn't know if that was on your radar at all, if you had any thoughts.
No.
Any tips. It's a new area for me too.
Yeah, I mean, scanning it and hearing you describe it, yeah, sharing de-identified data, definitely something that is already done in mass in different ways via both commercial networks. So Datavant, Komodo, IQVIA, all operate in that space. There's also sort of like nonprofit hospitals joining together to do this. So well established. In this case, UDS, probably a specific data set. Maybe the tooling that's available for other de-identification plays to that. But to me, this falls into customer demand, right? Fhir probably hasn't built the full implementation guide, hasn't fully figured this out. Yeah, actually they have. No, I see Fhir implementation guide. So it's going and pushing the vendor and saying, will you do this for us? And there's going to be vendor pushback because it's one of many things to be prioritized. I don't imagine any EHR has actually, I would be very confident saying no EHR has built this capability today, or it's very new. So
yeah.
That
for 2023, it's optional, but they're saying as of right now that for the 2024 reporting calendar year, it'll be required. So we have a grace period for sure. We have some time, but it's just kind of hard to wrap your head around how to get it going.
Yeah, I would just engage there's 2 routes. Like you have to engage your EHR vendor, understand that the constraints to you, which have to be passed to them, and they're either going to say yes or no. And then if they say no, then building something or looking for a solution, a provider software solution to facilitate that is the way to accomplish it. But specific implementation guides, they're not guaranteed to be adopted. The ONC isn't saying across the entire US, you must do this. And so the more specific a requirement, whether it's state-based or something like this, the less likely you'll see it uniformly deployed or even deployed for a single EHR. But so it's a good example of some of the principles in the presentation. Last question I saw, how does Flexpa use Fhir? What's the benefit of Fhir? Mentioned this a bit at the beginning, but we provide access to claims data via Fhir, via patient authorization. This is because the CMS required this capability of all payers, all CMS regulated payers. So we benefit from that. By operating within Fhir natively, you don't have to make decisions as much. So like, what's the benefit of your database being Fhir or just using Fhir as much as possible? Well, if you have your custom database, you have this mapping that is constantly required to say, I'm mapping from Fhir to table 1 or table 2, rather than sort of just, there's always a little bit of mapping and tweaking, but your decisions about database format, you're just taking something off the shelf and adapting it and understanding it. And so there's some distinct advantages and trade-offs there. Anyway, we are 2 minutes over. Hopefully this was useful, interesting, entertaining. If it was incorrect, erroneous, as mentioned, hungry for feedback, hungry for your thoughts, feel free to reach out by any of the modalities, Twitter, email, or otherwise. And hope some of you come and click on Flexpa and ask what we do in more detail. I'd love to talk to you in that regard too. So talk to you all later. Thank you so much.